Time now for this week's Health Matters. Paul Critz with you, along with PA Lynn Szabo. And today we're covering a topic that actually I find low-key terrifying.
Yeah.
Sleep apnea. You just can't breathe anymore when you're asleep. I can't.
You just stop breathing.
I had in the past. I had a spouse whose apnea got pronounced after pregnancy, and I just lay there at night and nudge her to keep her alive. It just was, yeah. Sleep apnea is really is it as terrifying as I want to make it in my mind?
Oh, pretty much. You're looking at the immediate terror of it, but there's also long-term terror.
Oh my God. Okay.
Yeah.
All
So
right.
obstructive sleep apnea is just that. Is people who, because of the way their neck is, or because of the way their obesity or their gender or, other risk factors, their age, that they actually what happens is as they're lying, sleeping, their tongue falls back and blocks the throat. And so the income of air is drops to zilch. So, and then what happens is your brain is like, hey, not enough oxygen. and it kind of wakes the person up, but not completely.
Uh-huh.
So they have these mini waking up spells that go on through the night.
It can be innumerable through the night, right?
Right.
Every minute or so it can be like that.
Every 4 or 5 maybe. But
when I was laying, it was like every minute. But that's a specific case. Sorry.
Okay. And then what happens is the person wakes up with a headache. They feel like they're not they didn't get any sleep at all. They're usually mad at everybody around them because everybody was too noisy and kept them awake.
Oh, wow.
And that's not really what's happening. And then somebody comments like, you snore like a freight train, just like grandma, you shake the windows. And then hopefully what happens is the astute provider somehow becomes aware of this and can address it with a sleep study. And that's the reason actually I wanted to talk about it today for 2 main reasons. One is that people have significant down the road consequences of this. And all of a sudden in Del Norte, it's easier to get a sleep study. It's a more patient friendly process. And
All of a sudden?
yeah.
Why? What happened? I mean, I guess we'll get to that, but
Yeah, we'll get to that. But I guess I could jump ahead.
Yeah.
But so the reason that it used to be hard is you had to get in your jammies and you either had to go up to Brookings and sleep in a sleep lab or go down to the sleep laboratory and associated with St. Joe's or Providence Hospital.
And there for a while, I swear to God, the sleep lab in Brookings was right on the highway.
Right.
Like you pass it right before you even got to Harbor, and it was on the right-hand side. And it was just, I would think how would that be conducive to understanding anything besides how difficult it is to sleep beside Highway 101 at night?
Right.
But that's
my whole point is people who feel like they don't sleep well get a little anxious about making sure that everything around them is optimal so they can sleep.
So, yeah.
And to have, what I would think is to be sleeping with somebody staring at you all night.
right in a strange place, in a strange bed. And
Yeah.
So any sleep lab is going to be problematic then in that regard.
Right, totally. And so they've changed the procedure to diagnose it where they put a pulse oximeter on your finger for the night. You probably have to tape it on so it doesn't fall off. So they get 2 pieces of data fundamentally with kind of looking at them over time. Okay, so they get the oxygen level and they get pulse. And so pulse is kind of divided into beats per minute, but also the regularity or irregularity of the pulse. Okay. So when I get the report from somebody who's just slept normally in their own bed, so they're a lot happier about doing it, and then I get kind of summations of those pieces of data, and then somebody interprets it on the sleep study side and says, do they have no sleep apnea, mild sleep apnea, moderate or severe, and they have all numerical basing for that. So what's new about this is there's a new way to actually get a sleep study done. So if somebody comes in to my exam room and I see that they have some risk factors, which would be aging, be male gender, would be obesity, would be a big neck, would be somebody saying like, I'm tired all the time, I have a headache when I get up, and I'll ask about the quality of their sleep. And they're certain that they could sleep normally if, so-and-so wasn't making that noise next door or the dog wasn't barking at the raccoons. They got like a million reasons why it's not their fault. And then I bring up snoring because pretty much with insurance companies, if you have witnessed apneic spells or somebody who has significant snoring, then they'll pay for the study.
Okay.
They used to be more of a barrier to care when you had to go into the sleep lab. And now they're like, yeah, sure, this is cheaper. We'll go for it.
Okay.
Of interest to me when I was researching this is 0 to 4 apneic spells at night is considered normal.
Oh, wow.
Yeah.
Wow. Okay. Okay.
That surprised me. But you could still get treatment for that if there were witness, if you only had 0 to 4 spells, but there was some comorbidity. Now, the other thing, since obesity is a comorbidity for obstructive sleep apnea, the new Ozempic-like drugs, and in particular the one that brand name Zepbound, is one of the ways you can get it for people. You can't really get it because their body mass index is high, but you can get it if you layer on comorbidities.
Oh, wow. Okay. All
So
right.
so sleep studies are being ordered like right and left right now in the clinic, at least my clinic in my pod. The other good thing that's happened with it is that it's computerized, which I don't usually see as a good thing, but the nurse that I work with is able to not only order them online, monitor the progression of, have we gotten results yet? Have they been sent the right equipment yet? But they also, they can get the results and they can call people in. So the whole process, instead of taking what seemed like years, is now actually a couple of weeks.
Wow.
So it's super good. And it's, I think that the patient, if they wanted to, could also monitor that online. They probably have a way to make an account and, get data mined.
Right. Get things in my chart or something. Yeah.
But somehow you don't have to call people and never answer the phone now. You don't have to have a referral that gets forgotten after 3 years. Whatever happened to that, and now the ability to do it up here is uncharacteristically efficient. So super happy about that. Now, why is it important to know about sleep apnea? Well, it's a treatable disease, so it can be treated in a couple of ways. One is the CPAP machine. So what it does is put continuous air pressure in to keep the part of the throat that's closing off and to keep the tongue from sliding back into the actual patent air, which should be a patent airway or an open airway. And you've probably seen somebody that has the equipment. It makes you look a little bit like an astronaut, kind of weird looking. A lot of people are intolerant of it because it'll dry out their mucous membranes, or it doesn't fit right, or they're fussy sleepers anyway, and they just don't like it on their face.
Right. It's like a strap-on mask kind of thing. Right. Yeah.
Right.
There are a lot of those in this community, aren't there? Wasn't that a concern when we lost power for that week and all the?
Oh, totally. I write little letters to Pacific Power constantly, like keep this person's electricity on as a priority. So yeah, a huge big deal, and nice work around things Pacific Power.
That allows you to do what? What does it allow you to do?
It's a one-page, not very onerous form where I could just fill it out and move on.
What does it get the patient?
It gets the patient sometimes a battery generated CPAP.
Okay.
Sometimes that, and that's also if people are unhomed or unhoused, they can get that, if they're living in a van or something.
Wow. Okay.
So that's helpful, but I think it also gets a priority of where to direct the power. So although I don't really know how they do that. but it seems to be super helpful.
Wow. Okay.
Yeah. So, of course, if somebody has sleep apnea, stopping breathing acutely and dying in bed is probably a thing that happens. But that's not what happens the most often.
Hmm. Does that happen?
Yeah.
Okay.
Oh, yeah. Well, people die in their sleep. That's probably what happened. Although it's hard to tease out whether they got the apnea because they died or whether...
I guess I always assume that would wake me up if I couldn't breathe like that.
Well,
but
that's
not necessarily
ideally
the case,
how
right?
it's supposed to work. But
Yeah.
what if there's some reason why you...
Right,
I don't
right.
know,
Medication,
you've taken some
you're altered,
medication
yeah.
or, something is altered about that. Your blood sugar is really high. I mean, you
Yeah.
know, not you, but hypothetical.
Right.
Yeah.
Your Jimi Hendrix. Yeah, that kind of thing.
Yeah. That was probably heroin overdose.
It was something
I
else,
think.
but yeah.
Yeah. But here's what, in the long run, the reason it's important to bug your provider, because it's not really on top of our radar like it should be. I'm obsessed with it now because I worked with a traveling doctor in our clinic who had it. And when doctors have a particular illness,
becomes
they
very-
see it everywhere. Oh my God, they
Okay.
see it everywhere. And also because I'm more likely to prescribe the Ozempic-like drugs for weight loss, and because it can't just say, look, this person needs it for weight loss. I have to pile on comorbidities. And so what happens is that people who have untreated sleep apnea are more likely to have heart abnormalities. I didn't see that coming. I have to say that kind of surprises me.
Okay, and in what sort of relation, if that's understood at all? Is it just
I think it's
corroboration?
because your heart has to work
Sure.
harder in order to circulate blood that's poorly oxygenated.
Okay.
So part of the abnormality is you get congestive heart failure or cardiomyopathies, which means an enlarged heart. Part of it is arrhythmias, and the most common one would be atrial fibrillation. So the heart just tries to do its best, and at some point it crosses the line and it can't. Metabolic syndrome, which is a precursor to type 2 diabetes, and in a lot of people kind of happens. So you get lower good cholesterol, higher triglycerides, and bad cholesterol, and then higher sugars, but not to the criteria that would entitle you for an honest diagnosis of type 2 diabetes, but kind of in like maybe a pre-diabetic zone.
Wow.
Yeah, and then obesity. And people are tired a lot, so they don't get out and exercise. They stop moving after a while. And then, that kind of worsens the burden on the heart if you're gaining weight. And they don't feel like they can solve that problem. They might kind of look at what they're eating, but really the exercise is the sustainable is what really is going to help people. So how can you do that if somebody is morbidly obese and really can't get out and go swimming in the evening or go hiking, go on a little ramble? Well, the Ozempic-like drugs are super helpful for this, and they have the specific indication that you can use them for obstructive sleep apnea. And when I got that notification sent to my phone, I could hear the insurance companies going, "Oh no, how are we going to make a barrier to care for this?"
Right.
Okay,
Wow.
and so what I do in my practice is, the obesity is what triggers the conversation about how you sleep. And people are kind of surprised because they don't know they're snoring necessarily. And maybe I'll have a couple married couple, and I'll say, "Do you snore?" And the patient says, "Oh, no,
Right.
And the partner is going, "Oh, yeah."
Rolls his or her eyes.
Oh, yeah. That's why I stay in the den and watch TV.
Is there any way to tell if you have sleep apnea, other than just, I'm just tired, kind of putting it together? I mean, is there?
Well, yeah, to have the sleep study, which now is much easier to get.
Yeah, but see, that's
so
not
you got to
answering
go
the
in and
question
talk
at
to
all.
your provider.
Okay.
Yeah, I don't think that anybody can self-diagnose because they're
asleep.
Right.
Okay.
Right.
And they're not breathing as good. So, hey,
I know. So they're not in their best frame of mind.
Yeah, right. Good point. Okay,
Yeah.
but so I guess I'm just trying to find a place if there's, just the ordinary average overweight older male Del Norter who might be like, I don't know, suspect that sleep apnea might be a part of their problem, but there's really
they might
no
have
way to.
high blood pressure that's hard to get under control, even though they're taking their meds. They might, oh gosh,
I guess, I mean, you say it's on your radar, but how much is it on the radar of other health providers?
I
to
don't
ask
think
those
it's enough.
Yeah. I'm
I
trying to
really-
figure out a way around that
Because
situation.
I don't think, because we have 7.5 minutes in the exam room.
Right.
And the priority that the patient brings to us is not the priority that the payer wants us to focus on, and not the priority that the stupid computer wants us to focus on.
Right.
And I think the patient here with this education should go in and advocate for themselves, and also their children, because children can get this too. And what the typical child presentation is, they show up at the ear, nose, and throat because they've got quote unquote big tonsils. And everybody is kind of used to thinking, well, getting tonsils out is kind of a kid's rite of passage. They rarely get them taken out now.
That's what I've heard.
Rarely.
Yeah. Neither of my kids had their tonsils out, but
Right.
it was
Neither
a
of
big
my
deal.
kids did. I didn't obsess about the size too much because neither of them had a problem breathing at night. But what the ear, nose, and throat guy in town, thank you, Dr. McCain, he's almost got the same note. Maybe you should test him for sleep apnea.
Wow.
So I've been starting to do that. And now that we can do it at home, it's so much easier.
What's changed now? You talk about now it's a matter of looking at a couple of pieces of data that you can get
Over time. Yeah.
over time with the pulse ox thing. What changed about that? How did that? Because in the past you've got to go do a sleep study. Was it just that pulse oxes weren't portable? I mean, what is it?
No,
Is
it's that
technological?
they were
change?
looking at it. They were collecting other data that, in the long run, appears to be superfluous.
So it was just a better understanding of sleep
right,
apnea.
and what they would
itself.
do is you bring your teddy bear and your jammies to the sleep lab, and then they would watch you sleep for about 4 hours. And most people would say, I don't know how they figured anything out because it
Right.
wasn't asleep, because their perception, oftentimes people's perception is they're not asleep and they're
Right.
actually
I
they
hate
have
those
like little
nights.
micro
Yeah.
bursts of sleep.
Yeah.
And then they wake you up about halfway through and they say, okay, you met criteria for sleep apnea.
home.
Now we got to put this mask, this
Oh.
contraption on you,
Oh my God.
demonstrate that it improves the situation, titrate it, kind of like you get glasses measured for your eyesight acuity issue. So titrate it to your own particular sleep apnea needs. And all of that has all of a sudden not important anymore. They just do the data. They collect 2 pieces of data over time at home, and then they send you the machine if you meet criteria.
Okay, the CPAP machine.
And then they kind of monitor you. So there's a big brother thing. So they know if you're not wearing it. They know if you wear it for 2 hours and then throw it across the room.
Sure, yeah.
And then you have to follow up. And so what happens typically, the patient experience is they come in, I think that it's a worthwhile study to do. They do a patient questionnaire called a stop bang. And then there's also another one that doesn't have as cool a name. And that's entered directly into the computer because it's all online now. And if they meet criteria, the insurance company agrees to the study, and they're much more agreeable now than they used to be. I think it's because it's cheaper.
Well, yeah, exactly.
Yeah.
You're not sending you off someplace for a
Right.
night or however long and doing
Right.
all of that.
And then they kind of wrap it up in 2 weeks instead of months. And so they get the equipment sent to them. They get some instruction, probably by phone, about how to set it up and how to titrate it. And then, people use it, and they're watching them to see if they're using it. If they're not using it, they inquire why, and then they refine the tool.
Wow.
Yeah. So super cool, but not everybody can use it. So I have some patients, mostly older men, whose necks are so massive, and the way they sleep is so, like they prefer to sleep on their abdomen. So they're prone and not supine, if anybody knows what that means, that they can't keep it on their face. It would become a suffocating factor.
Right.
And so they have something also brand new, super expensive, super cool, called Aspire is the trade name, not endorsing it, have nothing to do with them. Very hard to get up here. And that's actually something, kind of a electrical thing subcutaneously in the left upper chest, so you can feel it under the skin, kind of like a pacemaker or defibrillator. And every time it senses when the person's not breathing in it, and it stimulates the central nervous system to it's like a nudge, an internal nudge. It costs $30,000 to $40,000.
Jeez.
The closest person I could see who puts them in is kind of south of Redding.
Wow,
north of
really?
Sacramento. So
Oh my God.
and that's only one in Northern California the last time I checked, which was about 6 months ago. So I suppose somebody could go north to get it. But it is a surgical procedure, and it's a foreign body, subcutaneously. So if somebody had diabetes or something, then it's possible they could have problems with infection and things like that.
It's just as an aside, if something is difficult to, just regionally, as you were just describing with this,
Right.
Is that an indication that insurance doesn't want to pay for it?
Oh yeah,
Okay,
big time.
okay.
And you'd have to pretty convincingly fail the normal external CPAP in order to get insurance to pay for it.
Okay,
And this
okay.
is a surgical procedure. It's probably a same-day surgery. It's not that big a deal, but
Right.
I don't know. I think there's still some bugs that need to be
Yeah,
worked out of it. But some people are really excited about it because they don't want to wear the weird-looking mask, But I have not found anybody here
Why can't your Fitbit do this for you?
because it's not connected to your brain, your respiratory center.
Okay.
I don't know. It could make a little shock or something.
I mean, that's basically. I mean, you're talking about. It's like a nudge. Isn't that to your central nervous system? Wouldn't that just be a little shock? What else? I mean,
I think it's more like a TENS unit.
a what?
Do you know a TENS unit?
No, what's that?
Oh, TENS unit is used for pain, and what it does is you put electrodes on you, and then you hook it up to this little battery charge thing, and it kind of slowly feeds the nerves, a different, I guess, sensation than pain. It kind
Okay,
of blocks them by being kind of noisy background noise.
Oh, okay, I got
So
you.
I
got you,
don't
okay.
know exactly, though. And I don't even know if it goes into your brain because that sounds a little scary. It might just,
right.
yeah, it's so new that I don't know that much about it. I only have one patient who's even remotely a candidate for it. And you really have to have a good trial of failure at the CPAP in order to have it be medically justified.
Right.
I'd also kind of like more people to know how to do it, I think. Because
What?
anytime there's a new surgery, there's a practice
Oh,
period
I've
of
got you
time.
more doctors. You
Yeah,
mean,
it'd
not-
be
okay,
nice if they
okay.
practice on not my patients.
Okay, so you asked me to tell you we've got about 6 minutes left,
Okay.
and you've got something you wanted to pick up from.
So
First off, is there anything we need to leave this discussion of?
No, the
obstructive
thing you need to know as a good patient is go in and ask your provider, because I've seen sequelae where people somehow went through the cracks, and the sequelae are like heart attack, stroke, atrial fibrillation, lifelong anticoagulation. It just sucks. So be noisy with your provider. Don't make it number 17 on your list of 20.
Right,
Make
right.
it number 1 or 2. Then the next thing is a lot of people have been asking me how do they know if they're immune to measles, And most people who were standardly immunized, and I'll use myself as an example. So I'm almost 67 years old. I was born in 1958. So the immunization I got in 1963 for the measles was the first one made and was a substandard immunization.
Oh, no, seriously?
Not because it was bad, but because they went on and made better.
They got better.
Okay, science
Okay.
progresses. And so I happen to know that I'm immune to measles because as a healthcare provider, I have to prove that every place I work. And so, that's been a number of places.
How do you prove that?
You get a blood test.
Okay.
And so most healthcare providers have to automatically get that stuff along with TB testing, or can you prove that you're immune to Hep B
Gotcha.
or Hep A or the mumps, et cetera, et cetera. But so people who are kind of in my age group who were likely immunized in the mid 60s, it's probably a good idea to get proof of immunity. That's just a simple blood test. It's not a big deal. And you could have a medical need for it specifically because you have grandchildren. You're around a pregnant daughter-in-law. You want to build a wall around an unfortunately unimmunized child in your life, stuff like that. Now, Kennedy came out and said that you lose 4% of immunity per year in the population, so that older people are essentially not immune. This is a misunderstanding about science.
Okay, now is it a misunderstanding of what?
It's a misunderstanding of how science works in the science of
So I guess
immunization.
I just want to be clear. Is it a misunderstanding or is he just up wrong?
Well, he's wrong.
Okay, all right. Then that's
What is that, the Dunning-Kruger effect?
No, that's a subjective. That's a
Yeah.
subjective thing with the Dunning-Kruger effect and whether or not you know you're stupid.
Yeah.
But a misunderstanding would take something that arguably, let's say there's an argument here about the kind of things that you're judging, and you can misunderstand them to such a turn. That's a little more benign than just being straight up
Yeah,
ignorant.
trying
So
to give him the benefit of the doubt here, I guess.
that's what I'm trying to get you to not do, because he's in charge of all this stuff. So
Okay.
he's the last person gets the benefit of any doubt.
Well,
But-
he's also talking about things in a really changeable way, and one day it's this, and one day it's that.
right,
And so I think it makes sense
like a scientist would. Yeah,
Right. Some days. But I think it makes sense if people have been asking me that if you have this concern, go to your provider, ask for the test, super straightforward. All pregnant women get it as part of their initial OB exam.
Okay.
Are you immune to measles? And it kind of comes in a group of three. So it looks at measles, rubella, and mumps. And then if you really want to go, you could see, are you allergic or are you immune to chicken pox? Because that's part of the panel.
right. And
Yeah.
like I assume, I've never been vaccinated for the chicken pox. That came along after.
Oh yeah, I had the disease. Yeah.
Yeah, you had I didn't have the disease till I was like 28. And it was
bummer.
Yeah,
That's
no, it
dangerous.
wasn't. I know, but it wasn't bad. I had 3 things show up on my body, and I got a week off from work. I was sick for like 2 days, and then I felt better. So it was a nice time.
Immunization for chickenpox prevents shingles later on in life, which is a good thing.
I want to point out though, you got like measles vaccine number 1,
Right.
and you hadn't lost any immunity in
I have not.
the 50 years since then.
But I also got checked for hepatitis B immunization. I had 9 hepatitis B shots, and I never developed
Really?
measurable immunity.
Oh my God! Seriously? Oh no!
Yeah.
Wow. So you're impervious to the Hep B vaccine, then, is what you're.
I don't know. I did finally get immunity after I was actually exposed in wound care.
Oh, okay. There you
So,
go. Okay.
yeah.
Wow.
Yeah.
Okay. Well. Okay. That's how you find out whether or not. Whether or
Just
not.
ask your provider.
Are there other diseases you can just ask for like that? Is there a panel of diseases like you said that are like the mumps and?
It depends on why you want to know it. It's just so this is kind of like wanting to know your blood type. You don't, unless there's a medical reason. Insurance companies don't want to pay for it. So you have to say, look, my concern is that none of my grandchildren are immunized. We're trying to work on it, but I'm worried about what I'm seeing in Texas and now moving to Kansas.
That seems like insurance would go
Oklahoma.
for that.
Yeah.
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 Okay. Wow, very informative as always. Is there anything else you'd like to get in here, Lynn?
I'm thinking that for our upcoming show, I've been reviewing a chaplain at Sutter Coast, if I can get a
chaplain?
hold of him.
Interesting.
Yeah, what do chaplains do? I don't know.
That's it. That would be very interesting.
I think it's important, though.
Okay. All right. All right. We look forward to that. As always, we'll see you next week.
Bye-bye.